بسم الله والصلاة والسلام على الله. بسم الله توكلنا في جلستنا العلمية الأولى للمؤتمر الثالث للعلاج الطبيعي كلية التأهيل الطبي. بنرحب بالحضور الكرام كلهم. The first session include 6 presentation. Every presentation about 10 minutes. Maximum we can extend the time to 15 minutes. The discussion at the end of the presentation for 20 minutes. The first speaker is Dr. Maraim El-Shammari. Dr. Maraim El-Shammari is a senior physical therapist in King Khalid Central Hospital since 2019. She got her bachelor degree in physical therapy from King Saud University and the master degree from University of Pittsburgh in Pennsylvania. She used to be the female outpatient department supervisor in the rehabilitation center in King Khalid Central Hospital. And she is the director of the rehabilitation center also. Currently, she is training and education supervisor since October 2015 and the quality coordinator since October 2016. She is a member in training and health education and the rehabilitation and administration in the Ministry of Health. She has specialized in neurological and vestibular rehabilitation. Her interests are stroke, vestibular rehabilitation, and neuroplasticity. Her talk about conversion of the posterior canal to lateral canal, benign paroxysmal positional vertigo after canal 3 positioning maneuver. Now she can start, Dr. Mariam.
Assalamu alaikum. Thanks, Dr. Majdi, for the introduction. And I would like to thank Dr. Amal Al-Harbi for her generous invitation to share with you one of my rare cases that I've seen in King Khalid General Hospital. So today I'm going to talk about the conversion of posterior canal BBBV to lateral canal BBB after a modified Ible maneuver. It's not showing here the presentation. Okay, let's start. The background of this case report is, as you know, that BBV is considered to be the most common cause of vertigo among patients with peripheral vestibular disorders, and the posterior canal is the most commonest one. Sometimes, within unexpected causes, that posterior canal could be converted to lateral or anterior canal BBBV, and in our cases, that the patient has conversion to lateral canal BBBV. So at the beginning, what is BBBV? May some of you it's not familiar with this disorder. Benign is not life-threatening, paroxysmal sudden attack. Positional, it's with only specific head position. That is usually with the bed or roll over bed. Vertigo is incorrect sense of rotational movement. Usually it's like a spinning sensation. The pathophysiology behind the BBV is that the autoconia moved freely within the canal, causing dizziness whenever the patient is rotated. The symptoms is vertigo less than a minute. It's related to the change in head position. Symptoms occur when rolling over bed, bending over, looking up from supine to sit position. There will be no ear pain, tinnitus, or hearing loss, and there will not be any other neurological disorders for the patients. The types we have posterior, horizontal, anterior, as you can see here. The posterior one is the most common one. The least commonly anterior. We are really afraid about anterior canal because the downbeating nystagmus, 75% of the cases is due to neurological disorders. The nystagmus in the posterior canal is upbeating, torsional nystagmus, and the horizontal is directional changing positional nystagmus, geo or epigeotrophic. The provocative test for posterior canal Dix-Hallpike and sideline test, as you can see that the sensitivity, the specificity is the same, but the sensitivity is higher in the sideline test. The test that used for horizontal canal is a supine rule test. The difference between them, it's different, except the anterior and the posterior is the same, which is Eble maneuver. So the purpose of this case is to describe the conversion from posterior canal to lateral canal BBV while performing the canal repositioning maneuver, in other words, Eble maneuver. The aim of this report is to discuss the possible causes of the conversion and the management of the conversion. So our patient is a 28 years old male. He had a road traffic accident and then post-concussion. 3 weeks later, he felt spinning sensation. He went to neurologist, and the neurologist ruled out every other possible neurological disorders. So he came to us, and actually he denied when I asked him about the dizziness. What do you mean by dizzy? Because this is the first question you have to ask the patient when the patient come to you and say, I'm dizzy, because dizziness is it's a general concept. So he said, I feel like I'm spinning. He denied any history of hearing loss, tinnitus, or ear fullness, which rule out Meniere's disease. He denied any other neurological symptoms, for example, diplopia, imbalance, paresthesia, and weakness. The dizziness handicap inventory was 46, which is not, it's moderate, we can say. So I suspect that the patient may have BBV, so I start to use Dix-Hallpike test. It was positive, causing upbeating torsional nystagmus to the left. So it was left posterior canal BBV. So I applied canal repositioning maneuver, and he improved. Then after a week, within the follow-up, he was still dizzy despite the fact it decreased, and dizziness handicap was 22. The Dix-Hallpike was remained positive. I applied again the canal repositioning maneuver, and for optimal result, usually I repeated it 3 times per session. I will show you the video for during the Dix-Hallpike. As you can see here, this is upbeating torsional nystagmus to the left. Is it obvious, the video, clear? Okay. Within the same session, the nystagmus changed direction to B during the second trial. As I said, usually I repeated 3 times. So in the second repetition, while in the Dix-Hallpike position, the nystagmus changed its direction to be geotrophic nystagmus, most intense to the left. I'll show you the video on the right, then in the left. This is in the right position. As you can see, the direction of nystagmus to the gravity, that is why it's called geotrophic nystagmus. By the way, the patient is not aware about his eyes movement. This is the left is stronger than the right side. So I rule in lateral canal BBV to the left. So I applied Giovanni maneuver to treat the geotrophic lateral canal BBV. Upon discharge, after a week, the dizziness was 0. The patient free from symptoms objectively and subjectively. And the patient was fine even after follow-up after 3 months. So this is the first case for our department that got a canal conversion, posterior canal to lateral canal, and I treated the patient with the Giovanni maneuver. There's other treatments called barbecue, but I use this technique, Giovanni maneuver, and it's effectively improved the patient's symptoms. Even it's rare, but in the literature that they mentioned about the canal conversion, we can see as it affects 16 patients during Dix Hallback. That's why we have to wait from repetition. Among 85 patients having posterior canal, 6% of them could have a canal conversion to anterior or lateral canal. In 127 patients, canal switching occurring 10% of patients having horizontal canal BBV and 12% of patients having posterior canal BBV. This is comparison between Giovanni and barbecue maneuver. I've read one case report about canal conversion. They use a barbecue after the conversion, and the patient needs more sessions in order to improve. And this confirmed that the patient may improve. And Foster in 2012 mentioned that about 4 patients having canal conversion, 3 of them treated with Giovanni improved within 1 session. And this is also a systematic review. They make a comprehensive research including PubMed and FACE, Web of Science, Cochrane as data resources. Among a lot of cases, the inclusion was 3 cases, 3 studies. 2 of them have low bias. They compared that Giovanni with the sham maneuver and other with Giovanni with a barbecue. They found that and concluded that Giovanni is more effective than sham or barbecue maneuver. The possible causes: performing the canal positioning maneuver incorrectly, for example, doing extension more than 30 degrees or do it faster, moving the autoconia from posterior canal to lateral canal. Performing Dix Hallback test immediately after canal positioning maneuver. That's why we have to wait from 1 repetition to another in order to avoid canal conversion. Although canal conversion is infrequent, the characteristic of canal conversion between posterior to lateral should be identified and managed. In order to decrease risk of canal conversion, the maneuver has to be performed correctly and repeated more than once within the same session in order to get optimal results. Thank you.
Thanks, Dr. Mariam, for your good presentation and for your effective time management. Now, the second speaker, Dr. Magid, will introduce.
Now we will listen to Dr. Ahlam Dawas. Dr. Ahlam is a DBT student at College of Medical Rehabilitation, Qasim University. For her independent study research work, she worked under the supervision of Dr. Magdi Arafa. Her work was carried out in the Qasim region. Please come.
السلام عليكم. معكم أحلام صالح الدواس, graduate from College of Medical Rehabilitation from Qasim University. I will talk about my research proposal under supervision of Prof. Dr. Majdi. Title: and the correlation between the body mass index and the pulmonary function among a healthy adult females in the College of Medical Rehabilitation at Qasim University. Introduction: obesity is one of the risk factors that are responsible for many disease disorder, including myocardial infarction, cognitive heart failure, metabolic disorder. The percentage of obesity, this study in 2015 in the United States, بالميل من 10 to 34%, بالفيميل 15 to 36. WHO classified the body mass index under 3 groups. Group 1 اللي هو normal body weight من 18 to 24.9. هذا normal weight. الoverweight من 25 to 29.9. More than 30 هذا الobesity. هنا several studies shown association between the pulmonary functional abnormalities, and obesity in adults. The aim of this study is to investigate a correlation between the pulmonary function and the body mass index in a healthy adult female in a College of Medical Rehabilitation. The hypothesis there will be no correlation between the body mass index and the pulmonary function. A significance of this study, a correlation between obesity and pulmonary function has not been addressed among a healthy in a Saudi Arabian population, especially in the Qasim region. Also, obesity is a risk for many conditions, including a respiratory disease. If the study proved a strong correlation between the body mass index and the pulmonary function, a physical therapy should be achieved a weight reduction program to control obesity and avoid a lung disease. And here the material and method study is the cross-sectional study which conducted in the College of Medical Rehabilitation in 2017. As subjects, 60 female students and worker in the College of Medical Rehabilitation participate in this study and classified into 3 groups. Group A, normal weight, Group B, overweight, Group C, obesity. The inclusion criteria, age from 20 to 27, with student and worker in the college. The exclusion criteria, pregnancy, with surgery during the last 6 months, with cardiac disease, with respiratory disease, with subjects with skeletal deformity or chronic obstructive disease. الميجرمنت spirometry used to measure pulmonary function, والweight and the height scales to measure body mass index. Evaluation, how can to measure body mass index? We take the height in centimeters divided على الweight in kilograms. Spirometer هنا البايت of the spirometer عندي scan result والmouth piece والprint. Measurement, we take a peak expiratory flow rate, forced expiratory flow rate at the first second, forced vital capacity. A procedure, first nose clip, then put a mouthpiece in the mouth, and inhalate force fuel and slowly, then exhalate force fuel and slowly. Repeat the maneuver 3 times and take an average. Data analysis, we're using a one-way ANOVA. Now a result. Correlation analysis, we take between the body mass index and each characters. The body mass index and the peak expiratory flow, we show significant. Between the body mass index and the forced expiratory flow at 1 second, non-significant. Between the body mass index and the forced vital capacity, non-significant. Now we take a result between each characters. Between the peak expiratory flow and the forced expiratory forced at 1 second, non-significant. Between the peak expiratory flow and the forced vital capacity, significant. Between forced expiratory volume at 1 second or forced vital capacity, significant. From this study, we showed highly significant results between a different pulmonary function tests. However, the correlation between the body mass index and the different pulmonary function tests doesn't show any significant except peak expiratory flow. This picture show different comparison between 3 groups. A mean normal weight, B overweight, C obesity. Now discussion. Results of this study showed highly significant results between a different pulmonary function tests. Or correlation between the body mass index and the different pulmonary functional tests doesn't show any significant except the peak expiratory flow. This result can be explained by a mass loading effect of the adiposity in the thoracic cage and the abdomen on a respiratory mechanics, leading to decrease the chest wall and the lung complaints, decreasing pulmonary gas exchange, limiting an exercise capacity. This explanation agree with Oliveira in 2016, who showed that the overweight and the obesity is a growing risk factor in most countries, aggravating the factor for many respiratory disease. Also, a result of this study agree with Sun and Chen in 2015 and Al-Gubayyan in 2012, who found no significant difference in forced expiratory flow at 1 second, also forced vital capacity between obesity and non-obese subjects. However, there was significantly different in the peak expiratory flow between two groups. And thank you. يعطيكم العافية.
Thank you very much, Dr. Ahlam. Thank you, Dr. Ahlam. Now, Dr. Magdi will present our next speaker.
Okay. Third presentation, Dr. Noha Afifi. Dr. Noha Afifi is a professor of histology and cell biology, Faculty of Medicine, Cairo University. Dr. Noha Afifi is a quality assurance coordinator at Biology Department, Qasr Al Ain. Dr. Noha Afifi also is a member in reviewer board of cellular and molecular oncology. Also, Dr. Noha Afifi is a member and reviewer board of Permanent Scientific Committee for Promotion of Professors. Dr. Noha Afifi got a diploma of health profession education. Dr. Noha published many papers in international journals. Dr. Noha Afifi also is a speaker in the 7th Annual Conference on Stem Cell and Regenerative Medicine in Manchester. Dr. Noha, you can start.
السلام عليكم ورحمة الله وبركاته. بسم الله والصلاة والسلام على رسول الله. Thank you very much, Dr. Magdi. Now, my presentation. بس مش طالع هنا. مش بيتحرك. ممكن حد يشوف؟ My presentation is titled Comparative Histological Study on the Protective Effect of Folinic Acid versus Fish Oil on the Growing Bone of Methotrexate-treated young rats. Now, the background of this topic is related to acute lymphoblastic leukemia, which is a highly prevalent cancer in the pediatric age group, accounting for 30% of all pediatric malignancies and 70% of pediatric leukemias. Because of major advances in cancer treatment, most children treated for leukemia are now living into adulthood. Thus, long-term health of those survivors has come more into focus in recent years. Methotrexate chemotherapeutic agent is the mainstay treatment for childhood acute lymphoblastic leukemia. This chemotherapeutic acts by inhibiting the enzyme hydrofolate reductase, which is responsible for reduction of folic acid into tetrahydrofolic acid. Tetrahydrofolic acid is essential for the synthesis of purines and pyrimidines. Thereby, by this action, methotrexate inhibits DNA synthesis and cell replication, and that's how it acts by inhibiting the proliferation of malignant tumor cells. However, follow-up studies highlighted the effect of methotrexate in inducing stunted growth with short stature, diminished bone mineral density with subsequent osteoporosis, and bone defects in the form of fractures, especially in pediatric patients, as well as in long-term follow-up in survivors. Owing to the significant impact of methotrexate on skeletal health, it has become critically important to develop therapies to ensure bone health during the course of chemotherapy. Folinic acid is a methotrexate antidote used clinically to reduce methotrexate toxicity in soft tissues. Clinical and experimental studies have shown the potential of folinic acid in protecting bone during methotrexate treatment. Unfortunately, the use of folinic acid proved to reduce methotrexate cure rates in childhood leukemia, possibly supporting tumor growth and even cause cancer relapse. Thus, cancer sufferers are increasingly turning to alternative treatments, including natural products for better bone health and improved quality of life. Recent studies suggested that oral supplementation with fish oil omega-3 may protect bone during methotrexate treatment. The study was designed to compare the protection of folinic acid versus fish oil on the growing bone of methotrexate-treated young rats in an attempt to find better growth of bone and better quality of life for pediatric leukemia patients. The experimental design used 42 male albino rats, which were divided into the following groups. Corresponding control group, the group treated with methotrexate to discover the effect of methotrexate on the growing bone. Group 3, methotrexate treated also with folinic acid, and the last group, methotrexate treated plus fish oil. Methotrexate was administered to the animals in a regimen mimicking the protocol treatment for acute lymphoblastic leukemia in pediatrics. The drug is given in 2 phases. In the induction phase, the drug is given daily, subcutaneously for 5 continuous days, followed by 9 days of rest. That's now we finished 2 weeks of therapy to start the maintenance phase. From the end of the 2nd week till the end of the 6th week, the drug is given only twice daily. The same applies for folinic acid, given 6 hours after injection of methotrexate in the same induction phase and maintenance phase for the drug. Fish oil was available in the form of omega-3 fish oil raw material manufactured by Henry Lamotte, France, and it was given orally at a dose of 0.5 milliliter per 100 milligram body weight daily for 6 days. That's concomitant with methotrexate therapy for the whole duration of the trial. We measured the length and the weight of the animals, and then we started sample collection and processing after animal sacrification. Both knee joints from every animal was dissected out. We used the left knee joints for analysis and studying gene expression of rankel OPG using real-time PCR and measuring rankel OPG ratio. Now, what's this ratio? This ratio is considered a bone remodeling sign. Rankel OPG ratio is a bone remodeling sign, and a low level of this ratio indicates adequate bone formation and vice versa. Changes in this ratio are now taken into account in all bone diseases characterized by increased bone osteoporosis. On the other hand, the right knee joints from all rats were decalcified using 10% nitric acid, and then they were processed into paraffin blocks. We examined the morphology of the growth plate and the metaphyseal region. Why this region? Because this is the area of active bone growth, to correlate the effects on the experimental animals with that which actually happens in pediatric patients treated with the chemotherapy. While comparing the mean values of the rankel APG ratio, the highest value was detected with the 2nd group, methotrexate-treated group, which means that bone resorption and action of osteoclast is highly demarcated, while treatment with the folinic acid and fish oil improved greatly the ratio. The rat's length in centimeter also was decreased in the methotrexate-treated group and showed a statistically significant increase on treatment with folinic acid and fish oil, and even better results with the fish oil-treated group. By we examined the epiphyseal growth plate and the metaphyseal region areas of active bone growth, and in the control group, we observed normal histologic zones of resting, proliferating, hypertrophic, calcified, and then the start of bone formation at the site of the primary spongiosa area. Treatment with methotrexate, this one on the upper right, showed disorganized epiphyseal cartilage, loss of chondrocyte columnar arrangement, many areas of homogeneous matrix devoid of chondrocytes. These 2 photomicrographs for sections treated with the folinic acid and fish oil showed apparent restoration of the organization and thickness of the growth plate with organized zones of histologic areas. And the thickness of the growth plate was measured using morphometric study, because the thickness of the growth plate reflects the formation of primary spongiosa, which is reflected in the total length of the child treated with leukemia. In the group 2, the thickness showed statistically significant decrease compared to the control on receiving folinic oil and fish oil, the growth plate thickness increased with a better measurements documented for the fish oil treated group, group 4. Regarding the areas of the secondary spongiosa and bone marrow cavities, we tried to see the thickness of the bone trabeculae and the corresponding enclosed bone marrow cavities. Of course, on the methotrexate-treated group, bone marrow cavities were mostly occupied by adipocytes, which also reflects the effect of chemotherapeutic drug on hemopoiesis in the bone marrow with few hemopoietic cells, while the groups treated with the folinic acid and fish oil showed more thicker bone trabeculae and more hematopoietic stem cells developing within the bone marrow cavities. This was reflected in the morphometric studies, which showed significant decrease in the thickness of the bony trabeculae in the methotrexate-treated group, while increased thickness when treated groups with the other drugs. This stain, Mason's trichrome stain, also is an important stain to determine the areas of mineralized and unmineralized bone, which is reflected clinically on the bone mineral density, which may further increase the risk of osteoporosis and bone fracture in leukemic pediatric patients. The red areas indicate mineralized bone, and the blue areas indicate unmineralized bone. In the fish oil treated group, the best area percent of mineralized bone was shown in the trabeculae of the secondary spongiosa. And this was reflected by measuring morphometric study for the mean area percent and mean optical density of mineralized bone in the bony trabeculae of the secondary spongiosa, reflecting the highest value for the fish oil treated group. So, in the present study, using methotrexate chemotherapy model in young rats, mimicking the commonly used clinical acute lymphoblastic leukemia protocol, folinic acid and fish oil supplementation proved effective in preventing methotrexate-induced bone loss. However, fish oil proved to have better effect than folinic acid in ameliorating growth plate disruption and retarded bone formation encountered during methotrexate chemotherapy. We recommend that with adjusting the appropriate dose, it is advisable to use fish oil for young acute lymphoblastic leukemia patients assigned to methotrexate chemotherapy during the course of treatment to reduce the incidence of skeletal complications. Although it is generally believed that consumption of fish oil is relatively safe, more studies are required using different doses of fish oil to fully investigate the dose-response effects of this supplement in preventing chemotherapy-induced bone loss and to trace out any potential side effects. Thank you very much.
Great thanks to Dr. Noha Afifi for her interesting talk. Please, Dr. Noha, we need you with us. According to the recommendation of many of the attendants, now we open the discussion of the first three presentations for 10 minutes. Please, we need also Ahlam and Dr. Mariam, please, here. Dr. Mariam, Dr. Ahlam, please. Now we open the discussion of the first three presentations. Any question?
Assalamu alaikum.
Alaikum salam.
My question for Dr. Ahlam al-Dawaz about the correlation between body mass index and pulmonary function.
Yes.
About the design of the study, you divided the group into three groups.
Yes.
And then you compare between three groups. But the title is correlation. Why you divide the subject into three groups and not make a line of regression for the correlation?
بالريزولت.
Yes, in the design of the study itself.
الكروس سكشن study عبارة عن descriptive study with the same criteria. The number of the group يعني can be take any number of the group. But the result we put in the يعني figure.
So you divide it and then compare each group for each other.
Yes.
In normal body mass index compared to the overweight and then the obese.
Yes.
There is no difference between in pulmonary function.
Except the peak expiratory flow.
Yeah, I think that if you plotted a curve, a correlation curve between all the participated subject, okay, it may clarify the correlation.
Okay, thank you for this advice.
Thank you.
Thanks, Dr. Akram. Any other questions?
Assalamu alaikum. My question to Dr. Mariam, it's not related to her case report, but because she's, I know she is expert in vestibular, and I want to clarify for us what is the relation between the migraine and the balance disorder?
Dizziness? About the dizziness?
Dizziness or some, because some patients complain of spinning sensation, and they have vestibular disorders. And what is the relation? Maybe they have a migraine, what I'm thinking.
Yeah,
because they have a history of migraine. So what is the relation? And if you see some patients, can you explain for us?
As you know, that there is two types of migraine. There is migraine with aura, and there is migraine without aura. So one of the type for migraine with aura is vestibular migraine. So with vestibular migraine, the patient may have vertigo or spinning sensation and other symptoms, neurological symptoms. I think, I don't know, do you want me to clarify more about this answer? Because migraine is central disorder, and there's a change in, I think neurotransmitter within the blood that make dilatation of blood vessels with the brainstem, that it's related to vestibular nuclei, that it's close to vestibular nuclei. That's why some patients with vestibular migraine could have spinning sensation, and the treatment will be different for them from this case. Could that answer your question?
تفضل دكتور حنان.
Just to clarify, this is what is called basilar migraine.
Yes.
Yes, there is disorder in the basilar artery and every spasm. So you know that brainstem, like brainstem TIA. Yes. So this more obvious. What's called basilar migraine is there is migraine with vertigo.
Yes.
Just to clarify. Yes.
Thanks, Dr. Hanan. Any other questions?
Dr. Mariam, please, can you give us more description about Govan maneuver?
Govan maneuver? It's based on, for example, it's used for lateral canal. So if you have patient with lateral canal, you have to identify whether it's geotrophic or epigeotrophic. This is first. The geotrophic means the nystagmus toward the gravity, epigeotrophic against the gravity. So in geotrophic nystagmus, you will move the head over the uninvolved side. Wait for 30 seconds, then rotate the neck down. So the nose will be down for 2 minutes. If it's epigeotrophic...
From which position?
From sitting over the bed.
And try to change the position of the head?
You will rotate, make the patient lie down on the uninvolved shoulder. And the epigeotrophic to the involved side. So you will move the patient over the shoulder of the involved side. You will handle the head for 30 seconds, then rotate the nose down for about 2 minutes.
And this is mainly for the cases of external ear, not internal?
Yeah, only for the semicircular canal condition.
The cases of vestibular neuritis or labyrinthitis,
no,
we didn't make this maneuver with it.
No, the treatment is different. Usually if there is no compensation or adaptation after the neuritis for the patient, the patient is still dizzy, you know that the patient may have oscillopsia, and the head movement exacerbates the patient's symptoms. So mainly we are working in VOR gaze stability exercise, gaze stabilization exercise.
Okay, thank you. Please, another question to Dr. Noha about your presentation. I know it is more specific for the methotrexate and the fish oils, but what about vitamin D in these cases? It is a different?
No, it's a totally different issue. You mean the effect of vitamin D on bone preservation during chemotherapy?
Yes.
Yes, that would be another trial. But it, of course, has bone protective effect since it is essential for calcium absorption and deposition of calcium in bone. And it inhibits osteoclastic function in bone resorption. So it would be effective, but this would be clarified by another experimental study.
Okay, thank you.
Thank you.
Dr. Anna, please, also I have a question for you. What is your future recommendation in this very interesting topic?
I said that. Yes. Yes, Dr. Magdi, we recommended children starting acute lymphoblastic leukemia protocol therapy. Yes. Should be supplemented with fish oil. Now, all the studies show that with proper dose, not in leukemia patients, with proper dose, fish oil has no adverse effects. But overdose may cause some bleeding tendency.
Also, I'm asking about future research in this area.
Yes, future research. Yes. I said in my recommendation, we advise to make more future studies with different doses of the fish oil to discover out any potential side effects, because some research said that the fish oil increases bleeding tendency because it inhibits platelet aggregation. But this does not happen with adjusted dose according to body weight. Sometimes happens with overdose. So leukemic patients, acute lymphoblastic leukemia children, treated with chemotherapy, any kind, not only methotrexate, should have a natural preserver of their bone for better growth and to avoid the incidence of fracture, because the incidence of fracture increases about 39% at 12 months of chemotherapy, and this is a very high risk incidence. If fish oil proved to have these beneficial effects, it would be tried in humans. And if it's safety effective at all doses, it is highly recommended to start the treatment of leukemia patients, especially children, with this natural product supplement included in the protocol therapy.
Yes, thank you very much.
Thank you.
Can I ask?
Any other question? The last one?
Yes, this
one. Okay.
So, okay, Professor Noha PP, I just want to ask you something. What was the rationale of choosing folinic acid?
Because it is already implemented in the protocol therapy. That's what is given, because folinic acid is the antidote for methotrexate. It is already implemented in the protocol, but as I said, follow-up studies have shown that folinic acid, since it skips the point of the enzyme conversion I said, so it actually does not inhibit folate synthesis, and it proceeds in cell replication. So it decreases the efficacy of methotrexate in its goal. Its goal is to inhibit cell replication. It does not focus only on malignant cells, but actually on its way of mechanism, it inhibits the proliferation of other cells. So folinic acid decreases the cure rate of methotrexate and promotes tumor growth. And even in some cases, it was documented that it results in tumor relapse after end of the chemotherapeutic regimen set.
Okay, and the second question I just want to know, what could be the possible property of omega-3, fish oil?
The possible?
The possible property of fish oil over folinic acid.
Yes, it has two potential beneficiary effects. It acts on the bone marrow, stimulating hemopoiesis, so we skip the area of anemia and leukopenia encountered due to bone marrow depression encountered during chemotherapy, and it also has a very beneficial effect on bone-forming cells. Bone markers and bone serum levels of bone turnover measured during fish oil therapy proved very high efficacy level. Also, female patients taking fish oil during the period of menopause proved to have highest bone mineral density with marked reduced incidence of osteoporosis and bone fractures in the females consuming fish oil.
Thank you so much.
Thank you.
Dr. Noha, I have a question about.
The last
Okay.
one. Okay. The last one.
question.
I have a question about fish oil. You said how you measured the trabecula or thickness of trabecula for the rats, because you said that thickness only appears increased. How you measure it?
Because we have image analyzer morphometry system in our department.
Yeah, you depend only on the morphology of trabecula, but we have
no. Morphometric is not morphology.
Morphometric.
Yes, morphometric means measurement. We measure the thickness. We decide special areas, and it is a framework for the slide, and we measure the individual thickness for 10 areas, and we have the average. That's for each section of the slide. Morphology is determined by histological sections examined under the microscope, but morphometry measurements is identified by special microscope connected to a camera, and it measures morphometric arrangements according to the parameters you set for this image analyzer system.
Okay, sometimes we have a thick trabecula, but when we put the bone under stress-strain apparatus to measure the strength of bone, we find that the bone is already weak instead of its thickness of trabecular system.
Yes.
So I think it is a good way, maybe added to your research, if I wanted to measure the strength of the bone and make sure that it is very strength or it is good in a good condition. There is a healthy stress-strain apparatus which we dissect the bone and put it under it and apply weight to make sure that it is a very strength or biomechanical, from the biomechanical point of view, because not only not thickness of trabecula will reflect the strength of the bone.
Yes, that's right, Dr. Sohair. That's why we implemented Mason's trichrome stain. This stain measures the degree of mineralized and unmineralized bone. If the bone is not mineralized, so that's osteoid, non-calcified bone matrix, that would be very weak. If the bone is mineralized, it is properly calcified, and that appear also in measuring morphometric measurement, revealing statistically significant increase in the mean area percent of the areas of mineralized bone. Good mineralized bone means good calcification, means a strong bone. And of course, we shall integrate physiotherapy tests later on doing further studies, inshallah.
Inshallah.
Great thanks to Dr. Noha Afifi, Dr. Mariam, Dr. Ahlam, and also I am thankful for you for your very interesting discussion. Now, Dr. Magd will introduce the fourth speaker.
Now with our fourth speaker, Dr. Salma Abdul Muhsin At-Toyan. Dr. Salma is a DBT graduate student from the College of Medical Rehabilitation, Qasim University. Dr. Salma received her DBT degree at the College of Medical Rehabilitation in Qasim. Dr. Salma also served as a research fellow at the Medical Rehabilitation College Center. Dr. Salma is presenting a case report that was done in Burayda Central Hospital.
Assalamu alaikum.
She will talk for 10 minutes, then discussion for 5 minutes.
Assalamu alaikum. Welcome all. I am Salma At-Toyan, and graduating from College of Medical Rehabilitation. This is case report. It was done in Burayda Central Hospital under the title of Inpatient Physical Therapy Management for a 22 years old female with post-operative benign extradural spinal tumor in dorsal 6 and 7. Spinal tumor comprises a small percentage of reasons for back pain and other symptoms originating in the spine. The most common site of tumors that occur in the spine in the thoracic and thoracolumbar area, 70%. The sacrum area have more than 20%. The cervical spine is less frequent. To classification of the spinal tumors according to the anatomical location into two categories, extradural tumors, and intradural tumors. As you show in the picture, extradural tumors located between the bone structures and the dura mater, and is most common than intradural tumors بنسبة 50 إلى 55%. Intradural tumors can be subdivision into extramedullary and intramedullary. Extramedullary located within the dura mater but outside the spinal cord, while the intramedullary tumors within the spinal cord. And when the tumor compresses the spinal cord, it's the most serious cases. Therefore, intramedullary tumors most common than extramedullary tumors most common than intramedullary tumors. Spinal tumors can be considered as malignant or non-considered as benign. Both of them can cause significant disability when they occur in the spine. Benign tumors mostly seen in young patients, as our case for today. Spinal tumors may be growth and leading to multiple symptoms such as pain, loss of sensation, muscle weakness, difficult to walk, loss of bowel and bladder function, and in some cases paralysis. Symptoms varying according to the types and location of the tumors. The purpose of this case report was to describe the appropriate physical therapy, examination, evaluation, and intervention program for a 22-year-old female who suffered from post-operative benign extratumor in the thoracic 6 and 7. Case description: the patient was 22-year-old female. She was admitted to the ER of hospitals on 12 September 2018 by wheelchair due to severe middle back pain with heaviness and numbness of the abdomen and both lower limb. She left her college because she was unable to walk independent since 5 months ago. Pain was sudden onset and gradually increased in severity. The patient had no history of trauma or accident. She had surgery on the thoracic region before 4 days at the time of examination. Psychological history was good. She has lived with her parents. She has high energy and supportive family. The patient family history included diabetic mellitus and hypertension. The neurologist requested physical therapy to see the patient after 4 days of post-operative. On the thoracic surgery, types of surgery with tumor removal at the level of thoracic 6 and 7, because she was discouraged with her inability to ambulate longer distance without assistance from others. This is the picture for the patient MRI and show the tumors at the level of 6 and 7. The picture before surgery done. She described her pain 6/10 at the worst and 3/10 at the best on the numerical pain rating scale. The patient was in last semester of graduated from college. Therefore, she was very anxious to start the physical therapy sessions because she wanted mobility as much early as possible. The patient signed an informal consent along with the use of information in medical report. Clinical impression 1. The patient referred to the physical therapy following hospitalization. Should be examine her in range of motion, manual muscle test, neurological examination, and balance examination in multi-scales. The patient appropriate for this case report due to her complicated of dependent ADL. And also she was in young age and also anxious to start with sessions because she was to be as she was before without any limitation or restriction. Observation and palpation. The patient was conscious, oriented, communicating, and also cooperative. The vital sign was stable, and she was supine in bed at the time of examination. She was normal body weight. There was IV for her right hand at the time of examination. Chest examination was clear and symmetrical chest expansion. Surgical site was covered with. There was a flat cervical on the MRI, as we say in the previous slide, but it's not physically. There was no edema in the upper or lower limb. She can change her position from roll in bed and supine to sit without assistance, from sit to stand with minimum assistance, from stand to walk with moderate assistance. There was pain and grade 2 tenderness on the middle and lower fiber of trapezius. Grade 2, that's meaning there was pain with moderate palpation. There was calf muscle spasm on both sides. Sensation and deep tendon reflex for the upper and lower limb was intact. Active range of motion for the hip extension, abduction, and adduction was within normal limit, while other movements will show in the table. There was limited range of motion, especially for the left side. Passive range of motion was within normal limit for all joints. Manual muscle test for the muscle power will show in the table, but I wanted to focus on the trunk flexion and extension. The patient was +2. That may explain the patient is afraid from movement that should take in the spine, especially in the thoracic area, either stretched or contracted. Special test, bilateral Trendelenburg test was positive. That indicates there was muscle weakness, especially in the gluteal medius. Functional scales, FIM, functional independent measure, that assess the physical, psychological, and social function. It's 18 items. The patient scored 98 over 126. Function reach test, the patient scored 2.5 inch over the 10 inch. That was limited functional balance. Timed get up and go. This score is assess static, dynamic, and risk of fall. The patient scored 58 seconds out of 12 to 20 seconds. That was high risk of fall. There is risk fall score. It's called Morris fall score. The patient is, the nurse is recorded the result of a score in the patient file as the patient is admitted to the ER. It was medium risk. Clinical impression 2. Upon evaluation, the patient presented with bilateral lower extremity weakness, impaired static and dynamic standing balance, and decreased independence with functional transfers. The patient's chief complaint was severe middle back pain and difficult to walk independent. This patient appropriate for this case report because her primary goals before discharge from hospital to return to college with independent ADL and improve quality of life. It was anticipated that the patient would benefit from physical therapy sessions that focus on therapeutic exercise in the form of stretching and strengthening exercise and also gait training, and therapeutic activities in the form of static and dynamic balance exercise. Goals, the first of thing, short-term goals, decrease pain as much as we can, improve spasm and tenderness, maintain a range of motion of the bilateral lower extremity. The patient will increase the strength of the trunk and bilateral lower extremity to -4 over 5 to prepare for independent transfers. When the patient is increased up to -4, it's okay. but it's short-term goals. The patient will be independent with all bed mobility to improve functional independence. The patient will increase static standing balance to reduce the risk of fall. About the long-term goals, pain-free. The patient will retain full range of motion with pain-free and maximum strength. The patient will increase static and also dynamic standing balance to reduce the risk of fall. The patient will walk for a long time independent in order to retain prior living. The patient will be able to tolerate the time spent in sitting during lecture with pain-free, and this is the last long-term goal is the goals of the patient because she cannot tolerate time spent in lecture. The patient was taken. Okay. The patient was taken 5 days per week. Every session takes 13 minutes. The plan of care, including stretching and stretching exercise, static and dynamic balance training. Aim to strengthen the trunk and bilateral lower extremity and also improve function transfers. It was recommended that the patient begin outpatient physical therapy of open discharge to improve her endurance and improve quality of life. Intervention, breathing exercise, improve circulation, stretching exercise, strengthening exercise for the trunk and lower extremities, improve static and dynamic standing balance exercise, gait training, postural correction, especially for the cervical, patient education and instruction. First exercise should be focused on the muscle weakness. The first one, static abdominal strengthening exercise. The patient can hold 10 seconds, repeated 10 times. Progression of exercise should be start with easy for patient, then progress the hard exercise. Contract abdomen only, then abdomen with gluteal muscle, the last one, abdominal gluteal, and also for the thigh. The second exercise, trunk extension, and also there was progression, head raise, head and also shoulder, head, shoulder, and trunk. There was progression for this exercise as the hand beside the body and also behind the head. But my patient just do this progression. Bridge exercise, and also there was progression for this exercise. Knee flexion more than 90 degrees, it's easier for the patient. Less than 90 degrees, it's difficult. Standing on toes and heel exercise. Strengthening exercise for the gluteal muscle from different position. And also strengthening exercise for the abductor muscle from different position. After the patient doing the stretching and strengthening exercise, should focus on to improving the standing balance exercise. The patient bounce a ball with the therapist in one direction for the static, different direction for the dynamic. First of all, should be start with static when the patient is improved and will begin next to the dynamic exercise. Outcome, over the course of therapy, the patient reported moderate positively change in pain and function. However, examination should be occurred at the patient's last sessions to improve her keys in muscle, but the muscle strength was slightly improved. وهذا متوقع لأن البيشنت في الانبيشنت يونت ما يجلس فترة طويلة. The patient achieved 50% of her goals. The visual analog scale was decreased from 6/10 at the first session to 3/10 as at the last sessions. This is MMT for the initial evaluation and last session, and also the second table for the scales. The patient will improve it. For the function reach test was 2.5, the last session 7-inch. Time it get up and go, 58 seconds, the last session 16 seconds, but also there was limited for the time it get up and go. FIM 98, the last session 120. There is evidence for the early rehabilitation improve neurofunctional outcome after surgery in children with spinal tumors. This is a study supporting the physical therapy sessions to decrease the symptoms and also increase the quality of life. One of the strengths for this case report was the patient had steady emotional support from her family. She was excited for all treatment sessions and also complained of all treatment intervention. A limitation of this case report was...
Dr. Salma, please, 1 minute for the time schedule.
Just a slide. A lack of some point of re-examination, especially for the range of motion and MMT. The patient stayed in hospital for a short time. There was no special room for physical therapy in hospital, in inpatient unit. Therefore, it was so difficult to transferring the patient to outpatient physical therapy department. خصوصا لما نحتاج ممكن بعض البيشنت يحتاجون الكترو، يحتاجون او الستير او اي حاجه من الاوت بيشنت، صعبه انه ننقل الانبيشنت الى الاوت بيشنت، وما في غرفه مخصصه للفيزيكال ثيرابي في الانبيشنت. Future research should be conducted to further study the best physical therapy intervention to improve the functional outcome for patients after surgery of spinal tumors. Thank you. Any question?
Thank you, Dr. Salma. Now we are presenting our next speaker.
دكتور بيان. Dr. Ben is a DBT student at College of Medical Rehabilitation. He'll talk about physiotherapist behavior, attitude, awareness, knowledge, and barriers toward evidence-based practice in Qasim region.
Thank you, Dr. Majdi, for the introduction. Before I start, I want to ask you a quick question. Do you believe that therapeutic ultrasound is a good, effective treatment for plantar fasciitis? Just raise your hand for yes.
The question again, please.
Do you believe that therapeutic ultrasound is a good, effective treatment for plantar fasciitis? Who says yes? Who says no? Okay, good. There is a recent study in 2018 published in Journal of Sport and Orthopedic Physical Therapy that the ultrasound has a placebo effect in plantar fasciitis. Who's interested to read this study, please just capture for the topic. I will represent today my graduation project for independent study with supervision for Dr. Ahmed Al-Ahmari. The title is Physiotherapist Behavior, Attitude, Awareness, Knowledge, and Barriers Toward Evidence-Based Practice in Qasim region. Unfortunately, until now, I don't have any outcomes. There is no result, but I hope, inshallah, in the future, there will be. Physical therapy is considered as one of the most growing medical field, and physiotherapists should keep themselves very updated with the new research and knowledge to provide the best quality of healthcare in their clinical practice. To remind you about the definition of evidence-based practice, it's the using of current best evidence together with physiotherapist expertise and patient value in decision making. The goal of evidence-based practice is to improve the health and the quality of life through clinical decision. In 2017, Yani mentioned that utilizing of evidence in clinical practice depends on physiotherapist knowledge in searching and appraising journal articles, and also depend on toward evidence practice. For some statistics that's published in Ministry of Health website, in 2015, there is 8,082 cases attend to physical therapy center in governmental hospital. And there is also growing in number. In 2017, there is 32,924 cases also attend to physical therapy center in Qasim region on governmental hospital rather than the private center. We didn't know any number about the private center. According to the research topic, there is multiple study under the same topic in last years. All these studies agreed that physiotherapists have a positive attitude toward evidence-based practice. They are interested to read the studies to update their knowledge and improve skills in clinical practice. So according to last study in Saudi Arabia that's done by Al-Shahri in 2017, we contact with the author, and he said there is no data that indicate the physiotherapist from where. It's just open sample. There is no shown that in Qasim or Riyadh or any region. So my goal is to indicate the study on Qasim region and physiotherapist here. Also about the survey structure, it did not investigate in-depth data, particularly in barrier and knowledge. Each section only 6 items for the questionnaire, and attitude only 4 items. And also the number of DBT was limited. Only 3 DBTs participate in his study. So the aim of the study is to understand behavior, attitude, knowledge, beliefs, and the skills of physiotherapists toward evidence-based practice at Qasim region, explore if there is any relationship between demographic characteristic of participant and their use and application of evidence-based practice, investigate the barrier and obstacle of physiotherapists, and this is the main goal of the study, explore view of physiotherapists regarding to evidence-based. The method, the study will be mixed method, qualitative and quantitative. We will use the questionnaire and interview. The sample, physiotherapist practitioner from Qasim region, inclusion criteria, qualified physiotherapist who's obtained their bachelor degree in physiotherapy, registered physiotherapist practitioner with Saudi Commission for Health Specialties, physiotherapist who's currently provide physiotherapy services or education. Exclusion criteria, a physiotherapy student, a physiotherapy technician, retired physiotherapist, physiotherapists who are away from practice more than 1 year. Data collection. For the survey structure, we have so many questions. 11 questions about demographic information, 12 questions about attitude, 13 questions for knowledge and skills, 19 questions for awareness, and 60 questions for behavior, 10 questions for barrier. The validity and reliability for this question is measured, it's taken from previous study. Demographic information will be the age, gender, job title, nationality, education, work setting, physical therapy expertise. Interview procedure will be 10 participants or maybe more, it's depend. Semi-structural interview method, the participant chosen criteria will depend on variation according to demographic characteristic. Face-to-face interview, audio recorded, English or Arabic, then will translate. The main aim for interview is to investigate the barrier. For ethical issue, we will take the approval from College of Medical Rehabilitation and also from the hospital for interviews. the interviewee will be signed for the consent form. Information storage, all the participants will be anonymous. For data analysis, I'm not a statistic person. For data obtained from semi-structured interviews will be transcript verbatim in written form. We will use thematic analysis to analyze the interview. And for a questionnaire, we will use the IPM-SPSS. Expected outcomes. The result of a study will give useful information about the situation of evidence-based practice among physiotherapists, practitioners in Qasim region. This will help decision makers such as Ministry of Health and Saudi Commission for Health Specialties, and also it will give a great opportunity for college and universities who teach physiotherapy to evaluate and improve education outcomes. It also can help the manager and policymakers in human resources, education, and continuous training center in hospitals for better use of evidence-based practice in physiotherapy facility. At the end, I just want to give you a little information. The first physical therapy research was published in United States in March 1921. Thank you. Any question?
A lot of thanks to Dr. Bayan Sulaiman. Now, if there is any question for Dr. Bayan. Any question?
لا حد يسأل ترى ما أحد يسأل.
Thanks, Dr. Bayan. A lot of thanks. Thank you.
شكرا.
Now, Dr. Magid will introduce the sixth presentation.
Now with our sixth and last speakers, Dr. Dalal Al-Harbi. Dr. Dalal is a DBT student at the College of Medical Rehabilitation in year 6 and last year, inshallah. The work she is presenting is a research work carried out by her and Dr. Noura Salama under the supervision of Professor Dr. Nahid Bano for the requirement for the independent study course.
Good morning. Thank you, Dr. Majid, for this introduction. Good morning, everyone. I'm Dalal Al-Harbi, DBT student at Qasim University. My study focusing on the correlation between body mass index and transplant in physically active adults. It's a preliminary study conducted by me and my colleague Noura Salama, supervised by Dr. Nahid Bano. First, many active people or professional athletes suffering from pain at tibial bone after they doing certain type of exercises. واضح? After they doing certain type of exercises, that can be worsened enough to deteriorate their performance level, or even to exclude them from professional competitions. When we try to prevent it or treat it, it's tough because its risk factor remain unclear till now. That's what motivates us to do this study. So let we start. First, what is transplant? Transplant or medial tibial stress syndrome, defined by American Medical Association in 1966, a pain or discomfortable condition in lower leg due to high impact activities like running or jumping on hard surfaces. It affects approximately 60% of all overuse lower leg injury, which is high percentage require our concentration. The pain of transplant comes in increased force on chin bone and muscle around it. That will lead to swelling and inflammation, and this will cause the pain. When we're talking about the risk factor of transplant, there is lack of agreement on contributing factor of MTSS or transplant, making the treatment complicated and increase the importance of prevention efforts. There is many factors of transplant, extrinsic and intrinsic factors, but in our study we focus on the body mass index. As we see here, in 2004, East and Whites conducted their prospective study, and they did not find a significant relation between body mass index and MTSS occurrence, while in 2007, Blisky and his colleague found a significant relation between them. But in 2009, Rassi and his colleague did not found a significant relation between them. Lastly, in 2030, Yagi and his colleague found a relation between MTSS and occurrence and body mass index only in female athletes. So for this, as you see, there is controversial in results. Why we do this study? Knowing the risk factor is very important. First, to help in prevention, and as we all know, prevention is always better than cure. The second is to reduce the financial cost. Athletes or active people spend a lot of money buying painkillers, changing their footwear, buying an orthosis, and all of this, no need for it when we know the factor and prevent it. Reduce the incidence rate, and finally, and important, to improve their performance level. The aim of this preliminary study is to determine the correlation between body mass index and chin splint in physically active adults. As we say, body mass index is one of the risk factors we studied in this preliminary study, but in our main study there is multiple factors, as we will discuss later. When you're talking about this study was conducted in sport clubs and Qasim University Clinic in Qasim region. It was epidemiological cross-sectional study conducted from 13 January to 5th of February in 2018, in which physically active adults from sport clubs, we take them from sport clubs for two reasons. The first is athletes with chin splint will be excluded from professional competitions, and the second, the risk factor on non-professional people, we will find it more accurate. Okay, then the physically active adults will be divided into two groups. The first is chin splint group, which is the case. The second is non-chin splint group, which is the reference. They will be equal in age, sex, gender, and physical activity level. The only difference between them is that chin splint people will have chin splint. The non-chin splint group do not have chin splint. Both of them, after they sign a consent form, will be complete physical activity questionnaire for inclusion. But chin splint group will have additional components for chin splint criteria. We will discuss it now. Then both of them, we will calculate body mass index for both of them as weight divided by height square before their training sessions. So what is chin splint criteria? Chin splint criteria defined at 2004 by Yeast and Whites. It has 4 elements must be present for each person with chin splint to be diagnosed as chin splint patient. The first is the pain must be due to exercise and remaining for hours or days after stopping the exercise. The pain is located in posteromedial surface of the tibia and for area more than 5 centimeters. There is discomfortable embulbation, and the tibial surface is uneven embulbation. To be included in our study, the subject age must be between 18 to 35 years old. They must be physically active. That means they're training for at least 3 days a week for 1.5 hours. Free from pain at time of investigation. The chin splint criteria, the chin splint group must meet chin splint criteria. To be excluded, patient with previous leg fracture, previous leg surgery, and ischemic disorders. For statistical analysis, we use SPSS version 24. We calculate the mean and standard deviation for participant demographic parameters. We calculate binary logistic regression to see the correlation between BMI and chin splint. We also calculate the prevalence risk to see the probability of having the chin splint. In our study, a p-value of less than 0.05 was considered statistically significant. In results, in our study, we have 19 physically active people, 17 female and 2 male was participated in our study. 9 of them having chin splint, which is the case group, and have chin splint, which is the reference group. This is the participant demographic data, age and height and weight. This is the mean and standard deviation for all. In the correlation, as we see here, there is significant relation between body mass index and chin splint. As you see, it is 0.025. And the relation was positive. That means for each unit increase in body mass index, that will lead to 0.35 increase in log odds of transplant. And the prevalence risk, we found that obese people have 3.2 more chance of having transplant than non-obese people. As you see, the first orange column is the patient, a transplant patient with obese. The second was obese people without transplant, and the third here is obese, non-obese with transplant. The finally is non-obese and no transplant. In conclusion, we found a significant relation between body mass index and transplant in this preliminary study, but the main limitation was the sample size. It's small, so it's reduced the power of analysis. In our main study, inshallah, which is under investigation now, we will take multiple factor and to see the relation between multiple factor and transplant in adults who are physically active. The second aim is to see what is the most common risk factor. To conduct the study, we take the ethical approval from Ministry of Health. That's all. Thank you.
Thank you very much, Dr. Dalal.
Any question?
Any questions?
Or comment?
Here.
صوتك واصل دكتور، ما يحتاج مايك. I'm sorry صوتي يروح ويجي، ما متعودة على المايكس هذه، ف I'm sorry إذا كان مو واضح صوت.
Thank you very much, Dalal, for this. I think I have to say this for as you're right. That was an excellent presentation.
Thank you so
much. That was an excellent presentation. The way you think about the design.
Thank you so much.
The way you think about the design, the way you understand the concepts, the way you see how you did the statistical analysis, you interpret the results, that is above average, I can say, excellent. So well done, well done, well done.
Thank you so much.
That's number one. Because you're good, I'm going to ask you a bit of a deep question, okay?
Okay.
So when you measured the risk just now, was it relative risk or absolute risk?
No, it's relative risk.
Relative risk. Why did you choose relative risk and not absolute risk?
Because it is a cross-sectional study design. We try to find the relative risk of the prevalence risk. I didn't understand your question.
So why did you choose relative risk? So comparing risk of shin splint, no shin splint, as to absolute risk. What's the risk, the absolute risk in individuals who have shin splints and no shin splints? Why did you choose relative risk to report?
I choose to compare, if I understand your question, I choose relative risk to compare obese with non-obese and shin splint without shin splint, and to see what is the prevalence of obese people will have shin splint in this study.
So you think not mentioning absolute risk is not an important factor?
No, it's important, but we take relative risk.
Okay, thank you very much.
Thank you, Doctor.
Other questions?
Any question?
Hi, Dalal. Hello. So,
hello.
I just, even though I'm a supervisor, but just one question.
Amazing supervisor.
Yes, the question came to my mind when you said that walking or running on a hard surface can have an impact for the development of shin splint. What about the shoes? Do they have any effect?
Yes, the shoes is one of, as we said, the shoes is one of the extrinsic factor, but if there is also controversial about the shoes the shoes of the footwear, but in our study we're focusing only on the intrinsic factors, which is one of them is body mass index.
Means it can have a better effect if the shoes are better?
Yes, but if there is a problem intrinsic, we should prevent it or treat it before we changing the footwear, or where is the while the problem is till now present.
Okay, thank you.
Thank you.
Other questions? Thank you, Dr.
Thank you so much.
A lot of thanks for all speakers and also for all of you. The second decision, inshallah, will be in 1 o'clock. This decision was directed by Prof. Magdi Ahmed Arafa, a prof of physical therapy, neurological and neurosurgical condition, and the doctor.
I'm Magid Basha. I think you all know me. I currently work as an assistant professor in our college. This is the end now. May you allow me to take a selfie with all of you, if we can, and then we return to the next session. Thank you.